Over 30 million Americans have been told their knee pain is osteoarthritis, which is the gradual breakdown of cartilage inside a joint. And the majority of them have been handed the same two options: manage it with anti-inflammatories, or wait until it is bad enough for surgery. Both options address the symptom, neither addresses the cause. And the cause, in the majority of cases over 60, is not primarily what the X-ray shows. What I am about to tell you is not in the pamphlet they handed you after your imaging results. It is not in the anti-inflammatory prescription, and it is almost certainly not what your orthopedic specialist said in the 4 minutes they spent reviewing your scan. By the end of this video, you will understand what is actually driving your pain, and you will have a protocol to begin addressing it tonight. The X-ray showed you the joint. Nobody showed you what is actually making it hurt. Now let me name the explanation you have almost certainly been given, because it needs to be said out loud before it can be properly challenged. You have arthritis. That is why your knee hurts. The cartilage is worn down, and there is nothing to do about that. That is the sentence, or very close to it, that most people sitting with this video have heard, and it contains a fundamental clinical error. What the research actually shows, across multiple large-scale imaging studies, is that a significant proportion of people with severe cartilage loss on X-ray report no pain at all, while people with minimal imaging changes report severe, debilitating pain. The imaging shows structural change. It does not reliably predict pain. Why? Because pain in the knee joint is generated by nerve endings in the synovium, which is the membrane lining the interior of the joint, in the joint capsule, in the tendons and muscles surrounding it, and in the infrapatellar fat pad, which is a cushioning structure beneath the kneecap that is one of the most pain-sensitive tissues in the entire knee. The cartilage surface itself has no nerve supply. None. If cartilage has no nerve endings, then cartilage loss is not what is generating your pain signal. Something else is. And something else can be changed. The arthritis label ended the conversation. The real conversation starts with asking what is actually firing the pain signal and why. Before I show you what that is, I want you to recognize the morning. You are lying in bed and the alarm has gone off, or the light has come through the curtains, and the first thought, before coffee, before anything, is the knee. You swing your legs over the side of the bed and place your feet on the floor, and those first few steps to the bathroom are a negotiation. The joint is stiff and tight, and the floor feels like an accusation. You shuffle slightly, favoring it, giving it 10 or 15 minutes to loosen before it feels anything close to normal. Then there is the chair. Getting out of it requires a calculation now, a brief internal assessment of how bad it is going to be today, before the hands go to the armrests and the weight shifts forward. The first second after standing, when the knee protests and you wait for it to settle. It usually does, but it takes longer than it used to. And the stairs. Going down is worse than going up, always. The slight lean to the side to favor the better leg. The hand on the railing that was not needed 10 years ago. The small, quiet embarrassment of being slower than the person on the step behind you. The life has restructured itself around what the knee will and will not allow, and the restructuring has happened without announcements. You stopped taking the long walk. You take the elevator. You sit near the exit at gatherings, so leaving is easier, and nobody has to watch you negotiate the stairs. And when you notice all of this, the thought you reach for is, this is just what happens. The cartilage is gone. I have to accept this. The cartilage is not what is making those first steps feel like that. And accepting a wrong explanation is not the same as accepting reality. Here is why you have never been told this, and I want to be precise about it. An orthopedic appointment is built around imaging interpretation and procedural decision-making, injections, surgery, bracing. There is no billing code for a 40-minute explanation of synovial fluid mechanics, quadriceps inhibition, which is the reflexive suppression of thigh muscle activation that occurs in the presence of joint inflammation, and movement retraining. The system is designed to identify whether a procedure is indicated. It is not designed to address the causes of pain that do not require a procedure. That is not corruption. It is a system optimized for intervention, not for the kind of conversation that takes 40 minutes and a whiteboard. Now let me show you what is actually generating your pain signal. Because once you understand the 3 mechanisms, the protocol at the end of this video will make complete physiological sense. The first mechanism is synovial inflammation. The synovium, the thin membrane lining the inside of the knee joint, is the most richly innervated structure in the entire joint. It is threaded through with nerve endings that respond to chemical irritation, mechanical pressure, and cytokines, which are chemical messenger proteins released by immune cells that trigger and sustain inflammatory responses. When the synovium is chronically inflamed, it produces excess synovial fluid, the lubricating fluid inside the joint that cushions and nourishes cartilage, which causes joint swelling, increases intra-articular pressure, meaning the pressure within the enclosed joint space, and generates a continuous, low-grade pain signal. This is not bone rubbing on bone. It is an inflamed membrane sending a continuous alarm regardless of what the cartilage looks like on the scan. Think of the synovial membrane like the lining of a sealed plastic bag. When the lining is calm and smooth, everything inside the bag moves freely, and the bag is comfortable to hold and flex. But when the lining becomes irritated and swollen, it begins to press against everything inside, not because the contents have changed, but because the container itself has inflamed. The bag becomes tight, pressurized, and sensitive to every movement. That is precisely what synovial inflammation does to the knee joint. The contents may not have changed significantly. The container is the problem. The second mechanism is synovial fluid starvation. Cartilage has no blood supply of its own. It receives all of its nutrition and hydration through the synovial fluid surrounding it, and that fluid is distributed into the cartilage only through movement. Every time the knee flexes and extends, the cartilage is compressed and released, drawing in fresh fluid and expelling waste products with each cycle. Sedentary behavior, sitting for 2, 3, 4 hours at a stretch, stops that cycle entirely. The joint stiffens, morning pain worsens, deterioration accelerates, not because of aging alone, because of stillness. Picture a sponge sitting in a shallow bowl of water. When you squeeze it rhythmically, it expels what it has absorbed and draws in fresh water with each release. Clean, nourishing, active. When the sponge sits untouched for hours, the water inside it stagnates. It dries at the edges. The cartilage in a sedentary knee is that sponge, not being squeezed, not drawing in fresh fluid, quietly drying out and stiffening while its owner sits in the chair. The third mechanism is quadriceps inhibition. When a knee joint is swollen or persistently painful, the nervous system automatically suppresses activation of the quadriceps, the large muscle group on the front of the thigh that is the primary stabilizer of the knee. This reflex is called arthrogenic muscle inhibition, meaning the reflexive reduction of muscle activation caused by joint inflammation or swelling, and it begins as a protective mechanism. The body is trying to reduce load on an inflamed joint. But in a knee that has been persistently inflamed for months or years, the inhibition becomes chronic. The quadriceps weaken. The knee loses its primary stabilizer. Every step, every stair, every chair transition is now managed by a joint with inadequate muscular support, which increases mechanical stress on the synovium, the meniscus, the two C-shaped cartilage cushions between the thigh and shin bones, and the fat pad below the kneecap. More stress, more inflammation, more pain, more inhibition. The cycle feeds itself, and nobody told you the cycle exists. These three mechanisms, synovial inflammation, fluid starvation, and quadriceps inhibition, are not caused by arthritis. They are caused by inactivity, inflammatory load, and a protective reflex that has overstayed its welcome. And all three are reversible. And this is the part that explains everything the appointment could not get to, because identifying your dominant pattern is what makes the protocol personal rather than generic. The first pattern is morning stiffness that resolves with movement. The knee is at its worst for the first 10 to 30 minutes after waking or after prolonged sitting, then loosens and becomes more functional as the day progresses. This is a classic synovial fluid starvation pattern. Most people with this pattern believe the morning stiffness means the arthritis is advancing. Clinically, stiffness that resolves with movement indicates a fluid distribution problem, not a structural deterioration event. The joint is stiff because the sponge has not been squeezed. Move it, and the stiffness clears. The second pattern is swelling and warmth. The knee feels warm to the touch, appears visibly swollen, and aches at rest as well as with movement. Most people take an anti-inflammatory and wait. Anti-inflammatories reduce the chemical signal temporarily, but they do not address the mechanical load and dietary inflammatory triggers that are sustaining the synovial irritation. The inflammation returns because its source has not been touched. The third pattern is giving way and instability. The knee wobbles, gives way on stairs, feels as though it might buckle. Most people with this pattern believe their knee is structurally unsound and fear that movement will worsen it. The instability stability is muscular, not structural. It is the quadriceps that cannot hold, not the ligaments. And progressive, careful loading is precisely what corrects it. Identify your dominant pattern. Keep it in mind. The protocol targets all three, but your pattern tells you which step to start with. Everything covered so far is the mechanism, the why behind what you feel every time you stand up or climb a step. What comes next is the part most people watching this will never reach. 3 tests you perform on your own knee right now that confirm which mechanism is driving your pain, and then the 4-step protocol that addresses it directly. 4 minutes. Stay with me. The first test is the morning stiffness timer. Think back to this morning, or your most recent morning with pain. How many minutes passed after getting out of bed, or after rising from a chair, before the knee reached its most functional state? Under 30 minutes of stiffness that cleared with gentle movement, synovial fluid starvation is likely the primary driver. Over 30 minutes, or stiffness that does not improve with movement, active synovial inflammation is dominant. The second test is the warmth assessment. Place the back of your hand flat against your painful knee for 5 seconds. Then place the same hand against the same location on your other knee. If the painful knee is noticeably, clearly warmer, not marginally different, but distinctly warmer, active synovial inflammation is present and is your priority target. If both knees feel similar in temperature despite the pain, fluid starvation or quadriceps inhibition is more likely primary. The third test is the single leg stand. Stand near a wall or sturdy surface for safety. Lift the non-painful leg off the floor and stand on the painful leg alone. Count how long you can hold that position without grabbing the wall or feeling the knee buckle. Under 10 seconds with trembling or the sensation of the knee giving way indicates significant quadriceps inhibition. Muscular reactivation is your highest priority. 10 seconds or more with reasonable stability suggests inflammation or fluid starvation is the more dominant mechanism. Write down your results. Your pattern identification and your 3 test findings together tell you exactly which step of the protocol to start with and push hardest on. Now let me tell you what is feeding every one of those mechanisms every single day. The first is prolonged chair rest used as pain management. When pain increases, rest feels instinctively correct. For acute injury, it is. For chronic knee pain driven by fluid starvation and quadriceps inhibition, rest is the direct opposite of what the joint needs. Prolonged sitting stops the sponge squeeze cycle completely, allows the quadriceps inhibition reflex to deepen further, and worsens morning stiffness severity the following day. Most people with knee pain rest more and move less because they believe movement will damage the joint further. The research on knee osteoarthritis consistently and clearly shows that appropriate movement reduces pain, improves function, and slows deterioration. Rest manages the symptom while worsening the cause. The second is an omega-6 dominant diet without enough omega-3 to balance it. The modern diet contains dramatically more omega-6 fatty acids found in vegetable oils, packaged foods, and grain-fed meat than omega-3s. Omega-6 fats are metabolized through the arachidonic acid cascade, the biochemical pathway through which they produce pro-inflammatory signaling molecules that directly sustain synovial inflammation. Most people focus on cutting sugar as their anti-inflammatory strategy. Sugar contributes, but the omega-6 to omega-3 imbalance generates a chronic pro-inflammatory state that no anti-inflammatory pill can fully override while the dietary source continues. The third is heel strike walking. Most adults over 60 land on the heel with the knee extended and absorb impact through the joint rather than the surrounding muscles. This transmits a sharp mechanical load directly through the knee with every single step, thousands of times per day, directly irritating the synovium and the fat pad. Most people believe their gait is simply how they walk. Heel strike intensity is a modifiable mechanical behavior, and reducing it measurably decreases intra-articular impact load. How old are you right now? Write your age in the comments. I want to understand exactly who is watching this channel, because the dominant pain mechanism shifts significantly between 60 and 75, and your age tells me which video to make next specifically for you. 3 allies begin interrupting the pain cycle starting today. The first is the seated knee extension, 20 repetitions per leg, every hour of sitting. Sit in any chair. Slowly straighten one knee until the leg is fully extended. Hold for 2 seconds, lower it slowly, alternate legs. This movement squeezes and releases the cartilage in a gentle, controlled pattern, restoring the synovial fluid distribution cycle that sitting has stopped and providing a non-threatening activation signal to the inhibited quadriceps. Free. Requires only a chair. The second is omega-3 rich foods daily. fatty fish twice per week, and 1 tablespoon of ground flaxseed daily. The body uses omega-3 fatty acids to produce resolvins and protectins, omega-3 derived compounds that actively resolve inflammatory processes in joint tissue. This is not supplementation. This is food. The third is the morning joint warm-up. 5 minutes of knee bends and ankle circles in bed before the first weight-bearing step. Bend and straighten each knee 20 times slowly while lying down. Rotate each ankle 10 times in each direction. This pre-distributes synovial fluid before the joint bears load and dramatically reduces the severity of morning stiffness. Free. No equipment. 5 minutes before your feet touch the floor. Here is what 15 years of clinical practice and everything covered in this video actually comes down to. No injection, no surgery consultation, no anti-inflammatory prescription. 4 steps, beginning tonight, that address the actual biological mechanisms generating your pain, not the imaging finding that your appointment stopped at. Step 1. Before your feet touch the floor tomorrow morning, while still lying in bed, perform 20 slow knee bends and extensions on each leg and 10 ankle circles in each direction. Mechanism: pre-distributes synovial fluid through the cartilage before the joint bears load, reducing morning stiffness severity in most patients within the first week of consistent practice. No modification required. This is done lying down. Step 2. Set a reminder on your phone for every hour of sitting. When it goes off, perform 20 slow seated knee extensions on each leg. Mechanism: restores the synovial fluid distribution cycle, delivers a graduated reactivation signal to the inhibited quadriceps, and reduces intra-articular pressure that builds during prolonged stillness. If even this is painful, reduce the range of motion. Extend only to a comfortable angle and hold there. A partial range is far better than no movement at all. Step 3. 2 servings of fatty fish per week, salmon, sardines, or mackerel, and 1 tablespoon of ground flaxseed stirred into oatmeal, yogurt, or soup every morning. Mechanism: shifts the omega-6 to omega-3 ratio toward anti-inflammatory balance over 4 to 6 weeks, directly reducing the synovial inflammatory load, generating the resting pain signal. Step 4. 10 minutes of walking daily, consciously practicing a mid-foot landing rather than a heel strike, a softer, more rolling contact with the ground on each step. Mechanism: reduces the mechanical impact transmitted through the knee joint with each stride, decreasing the daily accumulative irritation of the synovium and infrapatellar fat pad. And the referral signal? If the knee locks completely and cannot be straightened or bent, if sudden severe swelling occurs after minor activity, or if pain is worsening after 4 weeks of consistent protocol, request an MRI and a physiotherapy assessment. This protocol addresses the most common pain-generating mechanisms in the over 60 knee. It does not replace evaluation of acute structural injury.